Good afternoon, all. From the cardiology services, we are presenting an interesting case which highlights the importance of technological advances, how far we are able to see into the body, also highlights the importance of a team management, multidisciplinary approach, but most importantly, it highlights the importance of context generation in clinical science. That for any diagnosis, you need to generate a context, and the context generation almost always comes from the story. The case was primarily managed by Dr. Ramakrishna. He will take up the discussion and the questions, and it will be presented by Dr. Naini, Senior Resident in Department of Cardiology, along with other team members. So, Dr. Naini, please.
A very good afternoon. We'll start our case presentation called Humour in the Heart, which was an unusual manifestation of a rare disease. So, our patient was a 69-year-old lady. She was a graduate, a homemaker, a resident of Delhi with no prior significant history. She presented to us with the chief complaints of abdominal distension for 5 months, which was the first symptom, which progressed to bilateral pedal edema for the prior 3 months and progressive dyspnea and central cyanosis for the last 3 months as well. When the patient came to us, she was very sick. She was class 4, barely able to walk, came to the OPD on a wheelchair, could just make it into the room while walking with support. So for 5 months prior to presentation, she had insidious onset and progressive generalized swelling of the abdomen, which was thought to be ascites precox. This was accompanied by bilateral pedal edema that subsequently developed 3 months prior, which was dependent and pitting in character. Both of these features suggested right heart failure. This was accompanied 3 months prior to presentation by worsening central cyanosis with no peripheral cyanosis and no worsening with temperature or other stimuli, and dyspnea, for which she was class 4, as I said at the time of presentation. This dyspnea was characteristically worse when the patient sat up, and it was relieved when she lay down. This was all suggestive of cyanosis with the platypnea orthodeoxia syndrome. So, in her other relevant history, she had a past history that was only significant for a cholecystectomy 14 years prior, no significant personal or family history. Her gynecological history was significant for menopause at 52 years of age. When she started developing abdominal distension, she had undergone an ultrasound at an outside center and was diagnosed to have a fibroid uterus. So, keeping in mind the features of early right heart failure, in particular ascites precox, along with a suggestion of a right to left shunt as manifested by cyanosis and orthodeoxia platypnea syndrome, we kept in mind the following differential diagnosis. The most common three diagnoses: RCMP with the patent foramen ovale, CCP with a PFO, and organic tricuspid valve disease with a PFO. All of these three are most commonly implicated in predominantly right-sided heart failure and in ascites precox. There were other differentials that were also kept, including pulmonary artery hypertension with RV dysfunction or pulmonary stenosis with significant tricuspid regurgitation, but these were thought to be less likely even at the time of clinical presentation. Before being referred to AIIMS, she had been extensively evaluated outside. She had undergone an echo which showed severe tricuspid regurgitation. Estimated pulmonary artery pressures on these echoes were 50 mm Hg, which would correspond to a degree of moderate pulmonary artery hypertension. She was also found to have a patent foramen ovale, which was shunting right to left, along with mild mitral regurgitation and moderate aortic. For these findings, she underwent a cardiac catheterization subsequently, and on this was diagnosed to have idiopathic pulmonary hypertension with a TR or a tricuspid regurgitation that was secondary to pulmonary artery hypertension. Because of the diagnosed fibroid uterus, she was being planned for hysterectomy, but the same could not be undertaken because of her poor functional and cardiac status. So, for idiopathic pulmonary artery hypertension, she was started, as is recommended, on pulmonary vasodilator therapy. In spite of being on pulmonary vasodilator therapy for a period of nearly 2 months at the time when she presented to us, she was continuing to have clinical worsening. She worsened from NYHA class 2 to class 4 at presentation to us. When we examined her when the first time she was seen, she had tachycardia with a regular and otherwise unremarkable pulse, tachypnea with regular thoracoabdominal respiration, pressures that were normal and had no suggestion of pulsus paradoxus. She had a BMI of 19.3 kg per meter square with no significant signs of micronutrient deficiencies, but she was thin built and undernourished. On further general examination, she had central cyanosis. Her saturation in the sitting position was 81%, which improved to 87% when she lay down. And this was the same when checked in all 4 limbs. She also had pitting bilateral pedal edema that was present up to the knee. Her JVP was raised 9 centimeters above the sternal angle seen in a 45-degree position, which would correspond to an RA pressure of around 14. This had a prominent V wave with a rapid Y descent, and the respiratory variation was as expected. When we examined her cardiovascular system, her S1 was soft, S2 was found to be normal. There was a third heart sound that was heard at the left lower sternal border, and this increased with inspiration. We noted two significant murmurs, a great 3 by 6 low pitched, short systolic murmur that was also heard in the left lower parasternal region, and that also increased with inspiration, and a low pitched mid diastolic murmur in the same region. So all of this together was suggestive of a severe or a significant regurgitant lesion at the tricuspid valve that was subsequently causing third heart sound by increased RV filling and a mid diastolic murmur secondary to increased flow. When we examined the rest of her system, CNS and respiratory systems were found to be unremarkable. Her abdomen was, however, soft and uniformly distended. She had firm, non-tender, non-pulsatile hepatomegaly with a liver span of 14 centimeters and a 10 into 10 centimeter smooth, non-tender, ballotable mass in the hypogastrium. Her flanks were dull to percussion and shifting dullness was present on examination. So now, based on our clinical examination, most of the differential diagnosis that we initially had entertained now fell out of vogue. And our functioning clinical diagnosis became a case of decompensated heart failure presenting to us with class 4 symptoms, secondary most likely to organic tricuspid valve disease causing severe low pressure tricuspid valve regurgitation. The etiology for this in a patient of her age would be possibly Epstein's anomaly, could be carcinoid heart disease or endomyocardial fibrosis, or given her background of weight loss and systemic symptoms, could possibly be an indolent infective endocarditis of the tricuspid valve. Along with that, of course, she had a patent foramen ovale, which was shunting right to left and causing platypnea and orthodeoxia. So we subjected her to initial routine investigations. Her ECG was remarkable for low voltage complexes, a right bundle branch block pattern, along with a first degree AV block. Her chest X-ray demonstrated no cardiomegaly, lung fields were normal, and CP angles were also normal. Her initial laboratory investigations were significant for an elevated hemoglobin of 18.5, secondary most likely to the cyanosis she had since been having, and a mildly reduced serum albumin of 3.3. She was then taken up for cardiac catheterization. And now we see that the pulmonary artery pressures are not actually high at all. She has a mean pulmonary artery pressure of 11, which is normal. She also has a pulmonary vascular resistance index of 2.7, which again is completely normal. She, however, has significantly elevated RV end diastolic pressures and elevated RA pressures, both suggestive of significant tricuspid regurgitation. These were her echo pictures that were obtained when she was with us. So here we can see, so this would be the right atrium, the right ventricle, the left ventricle, and the left atrium. So when we run this, we can see that this is the tricuspid wall between the RA and the RV, and this has a significant regurgitant volume. And if we look at the morphology of the tricuspid valve leaflets, we see that they're not fully mobile. So if we compare them to the mitral valve leaflets here, they are in fact restricted and thickened. In addition to this, when we measured the gradient across the tricuspid valve, it was found to be elevated. So she had a picture that was suggestive of fixed thickened tricuspid valve leaflets along with tricuspid stenosis as well as tricuspid regurgitation. Interestingly, however, when we performed a more detailed analysis of her left heart, we found that her aortic valve leaflets were also in fact thickened, and she had a moderate degree of AR along with a trivial to mild degree of MR. So her final echo diagnosis was severe low pressure tricuspid regurgitation with a PFO that was shunting right to left with mild MR, moderate AR, and normal biventricular function. With this background, we now revisited her history, and she came up with an unusual tale that she hadn't previously. So she had a history of increased stool frequency, which had been insidious in onset and progressive for the prior 9 months. At presentation, she was having a stool frequency about 6 to 8 episodes per day, but her stool volume wasn't much, which is why she never came up with this history to begin with. All these stools were watery stools, non-bloody and non-mucoid. And this prompted us to think of the possibility of a cardiac or carcinoid heart disease. At this point, we got biomarker levels done. So 24-hour urinary 5-HIAA levels were done, which were significantly elevated, as were serum chromogranule levels. Now, with a reasonably short diagnosis of carcinoid syndrome with cardiac involvement, we thought that, as is common in most of these cases, she would have a gut carcinoid or a bronchial carcinoid that with possible liver metastasis. With this in mind, we proceeded to get a gallium rotatox scan, which Dr. Pratik from nuclear medicine will be discussing.
These are the baseline and post-op images, PET images. So as we can see in image A, there's physiological uptake seen in the pituitary, a little bit of uptake in the thyroid, normal liver, spleen, kidneys, and this is the bladder, which is seen as a linear sort of uptake. In addition, there is a large tracer avid mass which is seen in the pelvic region, which on CT and few PET CT images is seen as a midline large heterogeneous density mass with some areas of necrosis, and it is closely abutting the uterus and the adnexa. So, in looking at this image, the possibility was of a neuroendocrine tumor arising from either the uterus or the adnexa. And this is the image that we have after the patient underwent surgery, in which there is the mass is no longer seen. So it is a normal scan.
Thank you. So, as Dr. Pratik suggested, there was a mass in the adnexa or the uterus. To better delineate this mass, this was probably the neuroendocrine tumor that was responsible for all these patients' worries. To better delineate this mass, she was taken up for a MRI abdomen. So, as we can see here in T1 and T2 weighted scans of the abdomen, she had a hypervascular mass with areas of necrosis. The uterus was seen separately from this mass. This mass was thought to arise possibly from the left ovary or from the left adnexa. So now we have a patient who is in gross heart failure. She is frankly cyanosed. She has a saturation of 85%. She cannot sit up without being in distress. And she needs to undergo two major surgeries. She needs the mass removed and she needs cardiac surgery for the tricuspid as well as the aortic valves. We initially tried to stabilize her with heart failure pharmacotherapy, on which she had some improvement. Somatostatin analogs have been discussed in great detail in the management of carcinoid syndrome, but they have not been shown conclusively to prevent the progression of carcinoid heart disease, and certainly would not have benefited this patient who was in advanced heart failure secondary to carcinoid disease. So she needed urgent surgery. The major issue with surgical planning in this patient was that there was a concern that anesthesia or cardiopulmonary bypass may in fact precipitate a carcinoid crisis. It was thus thought that the only possible option for this patient was to undergo a multidisciplinary approach where gynecological as well as cardiac surgery was taken up in the same sitting. So, after putting the patient under general anesthesia, initially she underwent a left oophorectomy, which revealed a large encapsulated mass. And subsequently, the cardiac surgery was undertaken, in which the tricuspid valve was repaired with a ring annuloplasty and aortic valve was also repaired. She remains on our follow-up. So this patient was first seen in 2019. So on her 3 years of follow-up, her echo remains normal with a trivial degree of TR and mild degree of AR. She underwent biomarker levels recently in February, which were found to be normal. She underwent a repeat imaging at this time, which showed only a small node with slight subcentimetric node with slight uptake in the retroaortic area. And she is otherwise class 1, living a regular life and being as well as one could be. Pathological specimens for the ovary as well as the tricuspid valve were provided for a confirmation of diagnosis, and they'll be presented by Dr. Hina.
So these are the sections from the left oophorectomy of the patient. And in this, we can see that this part is the ovarian capsule. There's a little bit of stroma, and then there's a very circumscribed tumor, which is arranged in nests with some glands in between. So the tumor is arranged in nests, and the tumor cells are monomorphic. There is some sort of cystic change in various places. They have moderate amount of cytoplasm. They are very uniform, similar to one another. The nuclei are ovoid with finely granular chromatin. Triple chromatin is classically described, and the nucleoli are inconspicuous. Significant mitotic activity was not seen, and there was no necrosis. So immunohistochemistry was performed. The morphology was classic for a carcinoid tumor. So neuroendocrine markers were applied, and the tumor was diffusely positive for synaptophysin and chromogyne. And this is a proliferation marker, Ki67, which is showing only an occasional cell being labeled. So the Ki67 index was around 1 to 2%. So it's not very mitotically active or proliferative. It is a typical carcinoid tumor. The fallopian tube attached to the specimen was also free of tumor. The final diagnosis rendered was carcinoid tumor of left ovary. There was no capsular breach. Ki67 was 1 to 2%. and the fallopian tube was free of tumor, stage 1A according to Piligo stage. Then the tricuspid valve excision specimen was also sent to us. These are the H&E stained images of the tricuspid valve. On low power, we can see that this is the lamina fibrosa of the valve, and then there is a large amount of fibromuscular proliferation in the endocardial aspect of the valve. So all this is normally this is supposed to be a very thin layer, but in this is considerably thickened, and there is some sort of spindle cell proliferation involving large areas of the valve. On higher power, we can see that this is a portion of a chordae tendineae. Even around that, there is this spindle cell proliferation is also involving the chordae. And the cells are bland in nuclear morphology. They have some amount of cytoplasm, which will be highlighted in subsequent special stains. There was evidence of neovascularization. Normally, this portion of the valve is avascular. However, as part of the pathologic process, there was a presence of blood vessels. Again, we can see this spindle cell proliferation in this area. A portion of the papillary muscle can also be seen here, as well as here. So this fibrotic process was also involving the papillary muscles. There's presence of vessels at the base of the heart. That portion is. So in view of the presence, to characterize the spindle cell proliferation, markers for smooth muscle actin and desmin, which is a marker of muscle cells, immunostains were performed. These spindle cells were positive for smooth muscle actin. Here we can see that they are also staining the perivascular smooth muscle cells. And then this is the stain for desmin, although it is slightly weaker in stain intensity than the normal smooth muscles around the vessels, but desmin was also diffusely positive. So these cells are possibly smooth muscle cells or myofibroblasts. Staining for elastic stains was performed in the form of VVG, and we can see that there is no significant elastic tissue component in this. Elastic tissue would have stained black. We may be able to see a bit of the control here. Congruent staining was performed for amyloid to exclude the presence of amyloid, and the lesion is not congophilic. This is the Mason's trichome stain, which stains the fibrotic areas blue. In this, we can see the red color staining of the cytoplasm of these smooth muscle cells, which would indicate that they are myofibroblasts or smooth muscle cells. So that's it. With these features, we would as a diagnosis of cardiac involvement in a carcinoid syndrome, that is carcinoid heart disease, was suggested.
So what were the challenges we encountered in the management of this case? So this was an unusual presentation of a So this was an unusual presentation of cardiac carcinoid. So even when cardiac carcinoid does present, it presents usually with signs of right heart failure. For a cardiac carcinoid patient to present with cyanosis and platypnea orthodeoxia is very, very rare, as I'll be subsequently discussing. In addition to that, the echocardiographic findings of the tricuspid valve itself, along with the significant left heart involvement that we encountered, is not classically seen in cardiac sarcoid, carcinoid. And additionally, the patient had no systemic symptoms. So she had some history of diarrhea, but no flushing, no bronchospasm, no systemic symptoms of cardiac carcinoid. Ovarian carcinoid in itself is a rare variety of carcinoid. And in the absence of hepatic metastasis, it is unusual that any carcinoid syndrome would lead to carcinoid heart disease. So what we were encountering was a rare manifestation of a very rare disease. Primary ovarian carcinoid is described in a total of 1% of all carcinoid tumors and 0.1% of all ovarian cancers. And carcinoid syndrome in the absence of hepatic metastasis are decidedly unusual with a prevalence of less than 5%. It may, however, be encountered in retroperitoneal or hindgut tumors, which would bypass the portal circulation. The presence of left heart involvement in carcinoid heart disease heralds the presence of an additional lesion usually. So in our case, this was a right to left shunt. It could also be a bronchial carcinoid or very high levels of the hormone secreted from the original tumor. Cyanosis is a presenting feature of carcinoid syndrome, so we could only find iterations in 2 prior case reports in the last 20 years. And there's only anecdotal evidence for this. Of course, a right to left shunt would be causing cyanosis. This was our case presentation.
Thank you, Nani, and the rest of the presenters. As Dr. Kothari said, I think context makes everything, and the most important thing in this patient was the patient's son is a cardiologist in US. He was a non-invasive cardiologist in US, and the patient was admitted in 2 of the leading centers before coming to us. Out of desperation, out of last try, they came to us. Patient was admitted for 14 days in some of the leading centers, and CATs were done. The beauty of this center is that the patient is admitted. The resident give me a call that, sir, I think this may be carcinoid, sir. So this is the kind of, the only thing that is missing is talking in detail to the patient. So this patient was diagnosed just because of that. So no amount of echo, no amount of MRI can unravel this mystery this patient had. And everything was known. So if you look back, everything was known. That there is a tumor ovarian mass is there, and there is a TR is there, and the patient has other features are there. And in fact, the echoes were being shown in some of the leading centers in the world. Even the echoes were shown to some of the experts in Mayo Clinic also before coming to us. So no echo can diagnose this thing. What I mean to say is that I think we have to sit in such patients comes, we have to sit together and unravel the mystery, and no amount of investigation can solve this. Number one. And number two, I think the management was simplified once we made a diagnosis. Once the thought came, once the biomarker was done, then the rest of the things are very easy. But now comes the challenge. Like there are many challenges, like who should operate, whether the gynecological surgeons or the onco surgeons, and whether it should be done in the same setting or in different settings. That was a key issue. So then I think Deva couldn't join us, and Deva was kind enough to operate immediately. And I think Dr. Neha from gynecology is there. So they took the decision that they will do in the same sitting. I think they went off very smoothly, and the patient was extubated in the same evening. Like it was very smooth. And then Samir Rastogi is there, who has been managing the patient during the course also, and during the follow up also. I would like to have some comments from Dr. Neha.
Good afternoon, all. First of all, I thank you, sir, for inviting here. I'm coming from the behalf of Professor Nirja Batla, ma'am. She has operated the case. So, as we all know, and she has beautifully highlighted also, it's an extraordinarily rare case we have encountered with a very different presentation in the patient. So, at that time also, it's a real dilemma in our mind also, because she is a postmenopausal female with the ovarian mass. So, usually the management goes with like a total abdominal hysterectomy and bilateral salpingo-oophorectomy. But in this patient, she is a critically ill patient with the NYHA grade 4, and definitely a cardiac surgery is also being done along with our surgery. So we have to decide upon what kind of a surgery we will do. So we have took a decision of doing a left salpingo-oophorectomy for this patient, because to reduce the surgery duration, one, and definitely the patient will be on anticoagulants after the surgery, and doing a major surgery like a hysterectomy and doing a minor surgery like a left salpingo-oophorectomy, it makes a great difference in that. So we have taken a decision of doing that, and definitely after this histopath and the follow of the patient, it's a right decision. It shows that it's a right decision because the patient falls under the grade 1. So for that stage, definitely we can go for a conservative surgery. So it's well managed by the team. Thank you.
Any comments from the oncology side?
Reparative index. I happen to report the case, when it came as in the form only it was written patient is a known case of carcinoid tumor. So that made me to give the report, precise report with 100% surety, because this is not a very common case you see. And this kind of heart involvement is usually on right side. But if the patient has bronchial carcinoid or a very big ASD or patent foramen ovale, it can affect the left side also. Mitral valve and aortic valve also can be affected with carcinoid heart disease. Another thing is that this is very classical. The sheet quilt-like distribution of these smooth muscle or myofibroblastic cells, which was blurring the differences between fibrous and spongious of a normal valve, is quite classical. And in the left side, a change very similarly seen, like with fenfluramine anorexogenic drug use. It is common in the Western country because obese people tend to use this kind of anorexogenic agent. Anyway, it's a rare case and very nicely tackled by the clinicians and the surgeons. Thank you.
Thank you. Any questions or comments? Surgery, Deva couldn't come, sir. We had the surgical clips we didn't want to show because of, so they did a tricuspid valve repair and the aortic valve repair, sir. PFO. Tricuspid valve replacement. The bioprocesses. So they did bioprocesses along with aortic valve repair and PFO closure. We invited him, he couldn't come, sir. Sir, it was not very classical. Like we have a fixed idea like carcinoid means the valve will be stuck in an open position. That's what is commonly described. The valve will be stuck in an open position. That was not that classical. Like
that histology was
still
very
mobile.
classical. Histology was very classical
Yes,
and characteristic.
Histologically classical, and the same way involvement of aortic valve and the mitral valve. Even though we all know that PFO is there, it can get involved. That is another thing that immediately we couldn't in the echo lab. Otherwise, we generally can make a diagnosis in the echo lab. So that was one thing. Another thing is that presentation like cyanosis, new onset cyanosis. So 65-year-old coming with new onset cyanosis, carcinoid will be the last thing in your mind. So that is the other thing. And platypnea orthodeoxia, carcinoid possibly doesn't feature in the list of what we have been known or what we have been taught. Those are the things like. No. This was the same. We didn't catheterize again. I think we didn't catheterize. I think she presented. This was the same. Even they thought that it is the referral diagnosis was idiopathic pulmonary hypertension, possibly vasoreactive, responding well to pulmonary vasodilator. That was the impression they had. So this was done when she was started on 2 pulmonary vasodilators. Cath was done. Vital shunt, why orthodeoxia? Initiation valve.
Good afternoon, respected teachers and seniors. I am Dr. Pradeep, Assistant Professor from C.T.V.S. I'm here to present a case of a complex aortic aneurysm, ascending aortic aneurysm with a pectus excavatum in a Marfan pediatric patient. So this involved a multidisciplinary approach involving C.T.V.S, plastic surgeons, and cardiac radiologists and cardiac anesthetists. Here, the brief clinical history is like a 12-year-old boy who is presented with breathlessness on exertion with NYHA class 2 and palpitation and syncopal attacks. He had in the past no significant, apart from this, no other significant history. He's the only kid of the family with normal delivery, with normal milestones. So no other significant familial history. And for his failure symptoms, he has been treated on diuretics and beta blockers and ARBs. And on clinical examination, he had a well-built and moderately nourished kid, and his heart rate was like around routine. And he had in clinical examination, he had high volume collapsing pulse. And apart from that, he had a BP of around routine normal range. And in clinical examination, he had a Marfanoid habitus. All typical features of systemic features of Marfanoid habitus was there, with significant pectus excavatum as well. On clinical examination of cardiovascular examination, he had left ventricular volume overload features with early diastolic murmur in left third intercostal space. This is a chest X-ray showing cardiomegaly with LV type of apex and prominent aortic shadow, and also there is a scoliosis which can be seen here. On the transthoracic echocardiogram, he had a severe aortic regurgitation with LV volume overload features, and his aortic dimensions were dilated. There was aortic aneurysm and aneloaortic ectasia type of aneurysm with Z-score more than +7. And pre-op CT angiogram has been done for this patient, which Dr. Shavan will explain.
Good afternoon, everyone. These are the CT angio images. First, this is the coronal image showing the scoliotic deformity of the spine with convexity to the left. And this is the CT angio axial run. This patient, in addition to the scoliotic deformity, there is marked depression of the sternum, which resultant decrease in the anterior posterior diameter of the chest, and resultant displacement of the mediastinal structures to the left and compromised left lung volume. This is the site of maximal narrowing. This patient is also having dilated LV with mild global LV hypokinesia, and there is dilatation of the aortic root as seen in these images. This is at the level of aortic sinus, and this is at the level of aortic annulus, sinus, and sinotubular junction. These are the values, and these are increased. And this is the axial representative image showing the markedly decreased anterior posterior diameter. Actually, this image is to show the Haller's index, which is the transverse diameter by maximum anterior posterior diameter. It is almost 60, and it is markedly.
As Shravan has said, the pre-op Haller index was like, which is the maximum transverse by minimum anteroposterior diameter, which was the normal is 2, but here in this patient it is 67. So, and you can see the marked cardiac subluxation to the left hemithorax. This pulmonary function test, obviously it has involved the lungs as well. There is moderate to restrictive lung disease pattern. So, what to do in this patient? And definitely for aortic aneurysm, we have no doubt, because his Z score is +7, and by Simpson formula also it is more than 10, which is like cross sectional area by height. It is more than 10 in pediatric age group. One should go for a replacement. The aneurysm has to be repaired. So we had no doubt about this. But what to do about the pectus excavatum? So he had clinically significant pectus and involving cardiopulmonary compromise. We thought, like, should we do in the second sitting or leave it, or first repair pectus or not? This was the question. So if we repair now, yes, it is going to be a long procedure. It has its own challenges, multidisciplinary approach. And what if we attempt at second sitting? Suppose now you go for the aortic aneurysm, and then later stage you can get the pectus excavatum get repaired. But that is also going to be difficult for a plastic surgeon, because there are going to be additions, and for them it is a difficult one. Or just leave it. What if we leave it? Just repair the aortic aneurysm and get out. Just a brief on thing why the pectus happens. It's because of the unbalanced overgrowth of the costochondral junction, leading to a concave anterior wall. And it has a genetic relationship. It's more common in males, and especially in Marfan's connective tissue disorder. So how it affects the heart and lung cardiopulmonary compromise? It causes the compression of the heart, leading to restrictive cardiac filling and cardiac output. And same, it compresses the lung and leads to decreased static PFT. So as said before, if we don't repair? So what is the worst thing which can happen? So the worst thing is, like, if it's already an aortic regurgitation heart, while post cardiopulmonary bypass and aortic clamping, obviously the heart is going to be much weaker, and while coming off, and if we don't repair it, this can lead to significant aggravation of the cardiopulmonary compromise. The restriction will be aggravated, which can lead to acute cardiac compression, and worst case it can lead to difficulty in coming off the cardiopulmonary bypass. And second thing, so these aortic surgeries are, everybody know it's prone for multiple blood transfusion. That's high risk of bleeding, can lead to added lung injury, along with this pectus excavatum left in situ if not repaired. And post-operatively, even in ICU, he may be having difficulty in weaning off the ventilation. Also, he may require tracheostomy and inotropes. So there have been in literature multiple reports. This is from the Houston, Texas group. They have also had a problem. They repaired in the aortic root replacement in the Marfan, and they tried to come off. They had difficulty, and ultimately they didn't plan it before, and so they have to do it in an emergency sitting. And the patient came off and went home. These are all multiple reports which has been explained. The patient had difficulty coming off, and they had planned in a emergency setting. So we expected this complication. So we thought like we will do in a single setting. That was our plan. So we involved everybody. Like what we did was we did a Bental procedure, which is a composite aortic valve root replacement with the valve using a 21 injured aortic valve conduit, which is basically a Dacron conduit, polyester conduit, along with the pectus excavatum repair by a ravish technique. So now I will call Dr. Nihar to discuss about the anesthetic.
Thank you, sir. The anesthetic challenges which we were prepared for were the severe aortic regurgitation, which leads to low diastolic pressure, and hence maintenance of coronary perfusion was important. Because of high arched palate, these patients are difficult airways, and hence airway management is challenging. Similarly, because of joint laxity, positioning these patients for surgery and avoiding any injuries is important. Because of pectus excavatum, there is restrictive cardiorespiratory symptoms both intraoperatively and in the postoperative period. It was a major vascular surgery involving long duration of anesthesia with its implications. There were chances of massive bleeding and prolonged postoperative ventilation and adequate postoperative pain management. So for preoperative preparations, we followed American Society of Anesthesiologists fasting guidelines with NPO period 6 hours for solids and 2 hours for clear fluids. Pre-medication was given in the form of injection morphine 3 milligrams intramuscular 30 minutes prior to surgery. The medications like beta blockers were continued on the day of surgery, and the diuretics and angiotensin 2 receptor antagonists were omitted on the day of surgery, anticipating electrolyte disturbances in the perioperative period and intractable hypotension at induction. Appropriate blood and blood products were arranged. Since it was a difficult airway cart was kept ready, and antibiotic prophylaxis was given before the incision as per the institutional practices. In intraoperative monitoring, standard American Society of Anesthesiologists monitoring in the form of heart rate, electrocardiogram, saturations, non-invasive blood pressure, temperature monitoring, and end-tidal carbon dioxide monitoring was applied. Age-appropriate whiteboard peripheral IV lines were secured. Invasive arterial lines in the form of right radial artery cannulation prior to induction, and once the airway was secured, a left femoral header cath was placed. Central venous access with a triple lumen catheter was placed in the left IGV, and anticipating massive bleeding with massive transfusion, a intravascular sheath was also placed. Transesophageal echocardiography monitoring to see aortic regurgitation, aneurysm, its extent, any associated branch vessels involvement, presence of thrombus, aortic cannulation site for going on bypass, and de-airing at the end of surgery was done. Central nervous system monitoring in the form of cerebral oximetry, that is near infrared spectroscopy. Bispectral index monitoring was applied. Coagulation monitoring with appropriate surgical points with activated clotting time was monitored. Arterial blood gas monitoring for blood pH, presence of increase in lactate, anemia, and electrolytes was done. Urine output was monitored throughout the surgery. Because of long duration of surgery and anesthesia, physiological derangements were bound to happen, which were managed. We approached with a balanced anesthesia technique. We used inline fluid warmers and body warmer blankets. We used antifibrinolytics like epsilon aminocaproic acid in the dose of 50 to 100 milligrams per kilogram, both pre-bypass, on pump, and post-cardiopulmonary bypass. Blood conservation strategies were followed with use of cell saver. Organ protection like myocardial and neuroprotection was also done. With the balanced anesthesia technique with use of anesthetic agents like midazolam etomidate, which are sedative hypnotics, appropriate analgesics in the form of injection fentanyl and muscle relaxant was done. Once the patient was induced, the anesthesia was maintained with inhalational agent like sevoflurane and continuous infusion of muscle relaxant of cisatracorium. Hemodynamic alterations in the form of changes in heart rate, blood pressure, and cardiac output were managed with appropriate vasoactive medications and infusion. With constant vigilance, we could manage the patient well. This is mid-esophageal long axis view in mid systole showing the appropriate measurements, and in diastole showing the aortic regurgitation. Calling back Dr. Pradeep for further discussion.
We decided to go ahead with the aortic aneurysm surgery first and followed by the pectus repair. So first, there are multiple approaches like midline sternotomy approach and parasternal approach, and can go for an anterolateral thoracotomy. We preferred for sternotomy because one thing, we are very comfortable with this every day. It's our day-to-day practice, and also it gives the best exposure for ascending aorta and aortic aneurysms. So we did sternotomy, and then we repaired the aortic root and ascending aortic replacement with a valved conduit. Modified Bental procedure was done. So just a small clip to show what is the Bental. Here the aortic cannulation, it's a very kept it for 2 minutes only. Here the aortic and venous cannulation has been done, and one can see the aortic aneurysm here. Aorta is dissected. Cardioplegia. Now the aorta is cross clamped and aorta is opened. One can see the aortic valve. It's a tricuspid aortic valve, but it's a dilated root. This is the left coronary button, which is being dissected and harvested. Next is the right coronary button, which is also harvested here. So after harvesting, we have taken the valve conduit, and it is being implanted in the root. Now this there's a hole made in the graft to implant the left coronary button. Left coronary is getting implanted, and yeah, followed by which we do the distal anastomosis, which means the distal ascending aorta is anastomosed with the distal end of the graft. So the aortic continuity has been established, followed by which the right coronary button, which is left, is also anastomosed to the conduit, so that both the coronaries are implanted. After that, the dearring of the heart, followed by the cross clamp release. So we know that this ascending aortic surgeries, or all aortic surgeries, are prone for bleeding. So after coming off bypass, we use a routine 6P dictum where the protamine and products and pressure, packing, patients, and prayer. So see here, after all these measures, the bleeding was not that much. We are able to manage it. The high chance of in this surgery, not only the intraoperative bleed, but there lies a risk of potential chance of postoperative bleeding. If there is any BP shoot on the postoperative period, any one single episode of acute shoot in the bleed can lead to bleeding. So we were much worried about that. But if there occurs a bleeding in the postoperative period after the plastic surgeon has done the pectus repair, then it is going to be a mess. To re-exploration, we have to undo the whole of the pectus repair, and we have to look for the bleeding. So that was our main concern: what to do and how to ensure. So what we did was, there are two approaches. Either one can close the skin and leave the sternum open and shift to ICU, and the next day, if no bleeding, all bleeding is settled, then we can go for a pectus repair. The other option is like what we did was, we kept the skin closed but with sternum open and waited in the OR for 2 hours. We double ensured there is no bleeding, and once complete hemostasis has been attained, then we handed over to the pectus repair to the plastic team. So just before inviting Dr. Shashank, I want to say, like, we wanted to discuss this case because this is a common combination, the pectus excavatum with aortic aneurysm in a Marfan patient. So we anticipated this complication of the acute cardiac compression before only, because there have been multiple episodes or multiple reports in the literature. So if we are not anticipated, then we should have gone for an emergency repair. If it had happened, then we should have arranged everybody. It's become a like last time mess. So we anticipation of a complication, which we found important, and multidisciplinary approach coordination with everyone was good, which has to be anticipated. For this purpose, we wanted to discuss this case. Now I will invite Dr. Shashank to describe his aspects.
Thank you very much, Dr. Pradeep. Good afternoon, respected faculty member. So this is one of the classical case of multidisciplinary approach that we usually do, and AIIMS is I think is known for the one of the best multidisciplinary approach to all the patients in all the departments. So in this patient, because we had pre-planned that we will plan to do both the cardiac repair as well as the chest wall deformity repair in the same sitting. So we had planned for initially we were slightly bit confused that whether we should do the chest wall deformity first or we should do it later on, as Dr. Pradeep had already mentioned. So we followed the dictum that plastic surgeons are always the finishers. So we let the patient, let the C.T.V.S. team do the complete procedure. They have the patient safe, and once we get the go ahead from the cardiac anesthesia and the C.T.V.S. team that yes, we can do our procedure, then we went ahead, and this was the sternum closure. So before that, after the sternum was closed, we raised some muscular dissection on both the sides. Pectoralis major muscles were raised on both the sides to get adequate exposure of the costochondral junctions. And after that, all the deformed costal cartilages from both the sides, the costochondral junctions from the costosternal junction, were excised and in a sub-perichondrial manner. And usually we tried not to go beneath the perichondrium, so because it can injure the anteromediastinum or we can injure the pleura. So we removed bilaterally all the deformed costal cartilages, and then next that we was thinking whether we should leave the chest wall as such or we should do some kind of fixation. So we just felt that we had mandible reconstruction plates with us that we usually do in our mandible reconstruction cases in trauma or in onco. So we use those thoracic spanning mandible reconstruction plate, a single thoracic spanning reconstruction plate, and then we did use two on both sides to fix with the sternum, so that we had a semi-rigid kind of thoracic wall, and we didn't want to do a lot of plates in this system because the patient is just 12 years old and the patient will grow, and we don't want a lot of implants impinging on the chest wall. So this is the immediate post-operative result when we close the chest after removing all the deformed tissue. This is a fairly level. This is a frontal view. This is the profile view. This is the post-operative chest radiograph. No plate migration. All the screws were right. And I guess I will. Thank you.
And post-op, after the excellent repair by the plastic surgeons team, we shifted to the ICU. Patient's post-op recovery was good, and he had no significant brain output, and he was hemodynamically stable. So he was extubated after 12 hours, and he was shifted to ward on day 3 and discharged on day 8. So this is the picture showing his post-procedure pic of him. The pectus, previously the pre-op, it was the Haller was some 67, hardly 3 mm was the anteroposterior dimension. Post-procedure, it was like much better. The post-operative echocardiogram showed that the normal aortic valve function and LV function was also. Post-operative CT angiogram, Dr. Shavan will show you.
Postoperative CT angiogram showing there is no evidence of any collection surrounding the conduit, or there is no contrast leak. And you can see there is improvement in the anterior posterior diameter, which was previously just 3 mm. And we can see the aortic rib wall is showing normal movement, and there is no restriction of the movement. Just a comparison between the preoperative and postoperative axial image to show the improvement in the anterior posterior diameter. Same sagittal section showing the improvement in the anterior posterior.
That's all. Thank you, sir. We just wanted to present because of this to anticipate any complication such as severely subluxated heart to the left hemithorax. If we didn't plan, then we would have ended up in a typical scenario on table. We probably would have difficulty in coming off bypass as well. And so we planned with plastic surgeons, and they were ready to help, and we both sat together, and our radiologist and anesthetist, everybody has so much help. In fact, there was proper coordination with all the 4 departments, so everything went fine. And with these plastic surgeons, they didn't take any cost. All the bars and screw, I think they arranged themselves, and they have repaired without any extra cost for the patient. Duration was like we started by around in skin time was incision around 7 hours. Everything.
Indication of I had a couple of patients without any heart disease, severe pectus, and I kept sending them to orthopedics. They say we don't do C.T.V.S. They say there is nothing from our side. What is the ideal age and indication to operate on? No heart disease.
No heart disease.
Okay. No heart disease. If the patient has aesthetic considerations, then we can do once the chest wall is well formed and the patient can be taken up. If the patient is anesthesia, for anesthesia point of view, if the patient is fit, we can take.
Happy to operate in a younger fellow or beyond 40?
So in younger patients, the main issue is if we want to do implants, then we usually don't want to place implants in younger patients. So we would prefer if the patient is at least post teenage.
Excellent case. Thank you. Very nicely done. Occasionally, in the cardiac surgery occasionally cardiac surgery has to be repeated, as you know. So sometimes the valves, they have problem. So now, because of the chest wall surgery, and apparently there are some metallic implants also there. So what will the challenges? Suppose he needs a repeat surgery after 3 years or 4 years. What will be the challenges at that time?
Sir, that is one good question, sir. Actually, regarding the pectus repair, there are other techniques as well. Nus bar techniques are there. So we thought of this also, because if a patient requires redo surgery or any CPR, those things will be affecting. So it has to be tailored for a cardiac patient. So these bars and things, if it is there, it will be difficult. So one has to tailor. So we ruled out that option in this patient. So less Dr. Shashank.
The mandibular reconstruction plate that we put in this patient is simple. We just have to cut it and it will open, because we didn't put any screw in the midline. The screws are only at the ribs. So we can cut it in the midline with a plate cutter and it will open up. So that's why we only placed one transthoracic and one curved mandibular reconstruction plate with the sternum on each side rib. We only placed 2 of that. So only with the plate cutter it can be easily cut in between.
The defib can be.
You put a metal on the chest wall, and suppose you want to deliver a shock in the post-op period. Will they, come in between? They will disperse the energy of the shock. Will it be ineffective?
Intraoperatively, no issues, but postoperatively, I think you can give it air shock.
Because you will be putting up one paddle above the sternal wall. Because here you will be having a chest tube. So if you disperse
avoid the area where the metal plate is there, and we can keep it up and below, or even we have the
extremely good conductor.
Other option is pacing wires. We have the pacing wires. We can deliver the shock using the internal paddles with the low energy. Also, that is also another option. Immediate post-op.
You cannot deliver shock with pacing wires. No. Intra-op is different. I'm talking about ICU management.
Post-op, the plate area and screw regions need to be avoided. I can keep it up and below.
I don't know. I'm not sure. And second question is, once you have put so much of metal inside, if you send this patient to my ICU, I'll be really scared of deep surgical wound infection. Did the patient sustain any wound infection?
No. He was
No. So what did you do special that he didn't land up with an infection?
Sir, one thing we were sure, like we don't want to. We made a myocutaneous flap. They made a myocutaneous flap. We didn't separate this.
Covered the complete hardware with the bilateral muscle flap of pectoralis major.
They were both pedicle flaps with good blood supply.
They were both pedicle flaps from both.
And they
pectoralis
used the
major.
subcutaneous drain as well to take off the seromos to prevent any collection, and routine antibiotic coverage.
Great.